I'm Alison Twycross. I was a professor of children's nursing and deputy dean in a previous life. I am now chair of and the founding chair of the charity supporting healthcare heroes. And until the end of this month, I'm still editor-in-chief for evidence-based nursing. And thank you for inviting us to speak to you today.
Yeah, and Supporting Healthcare Heroes is a charity supporting healthcare workers who are living with long COVID. That's the one of the basic aims of the charity, although we have other aims. So I'll move on and tell you what we're here to talk to you about today. So we're going to give you a little bit of background about who we are and how long COVID impacted us. And we're going to do a little refresh on what long COVID is and how it presents. It's an evolving picture, so it's forever changing. We're learning more all the time. And actually, when long COVID was first being talked about, we didn't really understand what that was, what it meant. It's still a work in progress. We're going to cover some of the difficulties that people experience trying to access the right kind of care for long COVID. So service users in general, but obviously health professionals and nurses as well. What is support like when nurses want to try and return to work? What's that like? We're going to talk through where we're at in terms of infection prevention and control guidelines in terms of what's happening in the NHS, and we're also going to look at some evidence as well as what's happening out there non-evidence based. We're going to talk about safe air in healthcare settings because that is such a crucial factor of what's happening right now, and kind of our overriding feeling around this is that we don't want other healthcare professionals to get long COVID. It's not easy to live with. It feels like it's here with us to stay. So Alison and I have had long COVID from quite early on and can't say it's particularly improved. In fact, we've seemed to have acquired more symptoms as we've gone along, but we'll explain that a little bit more in a minute. So who are we? So we're both children and young people's nurses. We're both from the academic world as well. And as Alison explained, she was previously a professor. I'm still a jobbing academic as well. When COVID arrived, I was clinically vulnerable. I've got a pre-existing long-term condition, so I was shielding immediately. Alison actually caught COVID before the first lockdown, just before, even though she was in the vulnerable category. So she started to get sick quite quickly. I was shielding for months and months, but during the second lockdown, something happened. My husband was admitted to hospital and he brought COVID home. Because of this pre-existing long-term condition, I actually ended up critically ill in hospital for quite some time. But brilliant care, brilliant decision making. I made it home to my family and I'm hugely grateful for that. Just at the time I got home from hospital, the word long COVID was started to be bandied about a bit, but didn't really know what that meant and didn't know if I would have it. And it was only as the weeks kind of moved on that I began to realize that I wasn't the person that I went into hospital as, and that things had changed. Some of these pictures here, what they're all about. Vaccines have been instrumental in terms of being able to be back out in society for people like us that are vulnerable and really don't want to get an active COVID infection again. Every time that we get a reinfection, then the potential for long COVID symptoms to expand to further symptoms is increased, and Alison and I have both experienced that, and it's quite devastating when it happens. Obviously, precautions such as masking, hand hygiene, and how we stop, the virus spreading is really crucial again to us being out and about in society. So where are we now? Well, Alison was had to take early retirement due to ill health, and actually I'm not working full time anymore because I can't, which is not where either of us would choose to be, and so we're just talking about two of us, but this is an experience that is being replicated right across our society and right across our children's nursing society in the UK. So, we are just examples of what colleagues are experiencing across the UK and of course across the world. Having long COVID is something actually to grieve and accept in some ways, but we've experienced quite a lot of loss in a way through long COVID. For Alison, loss of her career. My career trajectory's changed, so because of my disabilities and health limitations now, I definitely feel there are things that I wanted to achieve in my career that I think that I'm not likely to achieve. Now I'm still progressing, I'm still able to develop, and I'm still doing a stand-up great job at work, I feel, but it has changed how I envisage my career as a CYP academic going forward. We've been left with impactful disabilities. I'll just give you a little taster of mine. So I'm profoundly deaf in one ear. I emerged from hospital with no hearing in one ear. I am breathless at rest. I have crippling fatigue, which is one, these are some of the very common symptoms that people experience with long COVID, although deafness isn't a common experience. Post-exertion malaise syndrome. I've had gynae problems. I've had lumps and bumps occurring all around my body where I've had, cancer investigations. Where's this lump come from? And then it'll disappear. Arthritis symptoms. I'll leave it there. Could go on. The collection of symptoms and the disabilities that arise out of that are quite significant. And because of what I was saying before, that, we have to be really mindful about how we are in society, who we socialise with, how we mix with people. Now I'm in work on campus, mixing with students, mixing with colleagues, many days of my week, but I don't walk around class the same like I used to. I distance myself, I'm masking up. I have to be measured about where I'll meet people and how I'll meet people and who will I meet, and does my fatigue allow me to meet people? And I know that Alison has very similar experiences, and it's changed the experience of being a social person quite significantly in my personal life, as well as how I operate at work as well. So what's long COVID like? Like any long-term condition, it's not the same every day. It fluctuates. There are terrible days, weeks, months, and there are times of better health and better well-being, but never back. I've never felt, since I've had long COVID, and I had it about nearly 5 years now, I've never returned to the place of well-being that I had before I first experienced it. So it can be a spectrum. It can be a spectrum just in a day, where it starts off badly, but you can improve, where it starts off well, but you dip much earlier than you expect to. So having that awareness of that it is this very fluctuating experience, but sometimes it can be weeks and months of being in a real trough of well-being with long COVID. So I'll hand over to Alison.
Okay, so we've talked a lot about our experience of long COVID, and we thought we should offer a definition. And this is a relatively recent definition that we'd like, because it doesn't require a positive COVID test in order to have long COVID. And given the lack of testing at the beginning of COVID, and the fact that people, unless they're like me or Michaela, don't test very often now. So long COVID is an infection-associated chronic condition that occurs after a COVID-19 infection and is present for at least 3 months as a continuous, relapsing and remitting or progressive disease state that affects one or more organ systems. It does affect lots of different organ systems. It's different in different people. Some people get better for a while and then develop long COVID. I never got better after my first COVID infection in the beginning of March 2020. I was on immunosuppressants at the time, but it's kind of an umbrella term as well, because underneath it there are lots of different presentations, and research is being done to see if can identify, I can't like types, I can't remember the correct word, sorry, I have cognitive dysfunction. So what sort of symptoms do people have? Michaela's done this wonderful word cloud. Fairly early on, it was discovered that there were over 200 known symptoms of long COVID. Fatigue is the most common, and it's like a battery, you're kind of running out of energy. Cognitive dysfunction is very common, often called brain fog, but brain fog doesn't really capture it. And there are studies coming out showing that the impact on the brain from MRI and MRI studies. Post-exertional malaise and symptom exacerbation. So that is kind of, you do something, but then you pay the price. So as I'll talk about later, I went into central London for the first time in 5.5 years yesterday. Last week. But I had to go to bed as soon as I got home. And I was in bed for most of the next 3 days and felt pretty bad. I had a lovely time. Yeah. And for someone who used to commute 4 times a week, it was a bit shocking. Long COVID, the Disability Act does apply to long COVID, but on an individual basis. Long COVID isn't prescribed as a disability like MS or cancer. So it's really down to how it impacts the individual, and if it's going to impact you for 12 months or more, or is likely to, along with any other long-term condition, you can be defined as disabled. I'm on personal independence payment. My partner is my carer. I use a mobility scooter to exercise. But as Michaela said, it fluctuates. I didn't use a mobility scooter until I got COVID a second and third time, very close together. I developed all sorts of other long-term conditions after that. So I've edited evidence-based nursing for 15 years, so we've got some evidence in here that aren't particularly up-to-date and accurate data about the prevalence. In March 2023, the Office for National Statistics reckoned there were 1.9 million people living in the UK. They stopped counting on a regular basis then, but there was some data published, I think, in the GP survey that suggested that there were 2 million people in England and Scotland alone living with long COVID. It seems to be increasing. You can get COVID, you can get long COVID. The risk increases every time you get a COVID infection. So just because you didn't get it the first time doesn't mean you're not going to get it the second time. And every time you get it, the risk increases exponentially. And from what Michaela said and what I've said, you really don't want to be getting long COVID. I thought to talk about some of the risk factors, although please remember anybody can get long COVID. I think my family think I got long COVID because I had a dodgy immune system, and yeah, that's part of it. But you're at higher risk if you're female, between 35 and 50, have pre-existing conditions such as asthma, diabetes, or mental health issues. I was an asthmatic beforehand. You experience severe or multi-system acute illness. I was ill right before the first lockdown and probably should have been in hospital, but argued not to go in because it was in such a mess and it would have just been a disaster. You're also more at risk if you're in a socio-economically deprived area. as with lots of areas of healthcare, reaching some people are hard to reach, and so they don't get vaccinated. If you're unvaccinated and haven't had repeated boosters, and I realise most people need to pay for them. Even Michaela was refused a free one this time. Vaccination prevents you getting long COVID, and early antiviral treatment appears protective, often difficult to get, and obviously health inequalities play an issue. That I took those factors from two literature reviews, systematic reviews that came out last summer. Okay. So some other evidence I thought was quite interesting. Around 50% of people with long COVID meet the criteria for ME, chronic fatigue syndrome. I do. I don't have that diagnosis, but I meet the criteria. And also, the reason I've started using a mobility scooter in the last year is that long COVID can make you exercise intolerant. And my symptoms get much worse if I do exercise. So last summer on holiday, the 300 yards from my holiday cottage to the beach and back was too much for me. And I started getting all sorts of peculiar symptoms. I could no longer kayak or swim on the same day. And I would only go in for 10-minute swim or 20 to 30-minute kayak. And then I had to pay the price. One of the things I found is that a lot of healthcare professionals aren't aware of this exercise intolerance, and it does seem counterintuitive, and there's lots of studies coming out now looking at why it is. It appears our muscles behave differently. But when I was seen at Harefields Hospital, they wanted to put me on a pulmonary rehab program, and I went, no. So please bear in mind, if you're talking to anyone about rehab for long COVID, if they're exercise intolerant or get post-exertional malaise or symptom exacerbation after exercising, don't put them on a rehab program. So my final slide about evidence before I hand back to Michaela is in the 6 to 12 months and onwards, after you've had a COVID infection, you are at increased risk of a PE, a pulmonary embolism, stroke, a myocardial infarction, a kidney injury, a liver injury, Guillain-Barré syndrome, sepsis. You can get diabetes. I developed diabetes. Pneumonia requiring hospitalization. Postural orthostatic tachycardia syndrome. I've developed that too. And mast cell activation syndrome. Again, I've developed that mildly. So there are all sorts of complications and things. And this isn't a finite list. Just try and avoid getting COVID. It's really not worth it. I'm going to hand back to Michaela.
Well, we're just going to think about what it's like to try and access care. So I'll probably share a little bit more about my experience on the next slide, which is more about personal experience. But there's a really good paper by Turk et al. That was part of a larger study, and it was a qualitative study considering the perspectives of patients and healthcare professionals about what it's like to access care. Data collection was interviews, and the three themes were around patient effort to seek care, what interactions between patients and healthcare professionals were like, service resources and structural constraints. And actually, the key findings and the key issues that arose from that was that this effort that it takes to actually, number one, access care, number two, once you've got your foot in the door, but then you present as this person with many complexities, there isn't a one size fits all, and actually there's this very sophisticated multi-professional approach required. This massive push for the right care, treatment and referrals is really considerable effort. And that actually, understandably, there is limited knowledge and understanding in the professions about long COVID, and it's new, that's understandable, but resourcing is really difficult for these services, that there's been highs and lows, and we're really at a low really in terms of resourcing for long COVID services, means that this knowledge base just doesn't get to develop in the professions that are interacting with the users at that interface. And of course, one of the key professionals that service users are interacting with is the GP. So I'll just go on to the next slide. Oh, sorry. Have I moved past, or I'll just check. Right, okay. And tell you a little bit about kind of our journeys through long COVID clinics. So when I first realised that I think I've got long COVID after a couple of months of being discharged from hospital and still really struggling, my GP said, I don't know what to do, but I hear there's a local long COVID clinic. I'll refer you. So I got referred to this long COVID clinic that was a physio in a sports centre in a little room, who was doing his absolute best. But really, his job was to try and get me on a treadmill and walk, which, considering what you've just heard from Alison about post-exertion malaise syndrome, exercise intolerant, perhaps isn't the best way to, at first assessment, to be kind of dealing with patients with long COVID, but very little was known, and this physio was trying to do the best. So he got me walking on a treadmill, having my oxygen saturations monitored all the time, going, this heart rate's terrible. I don't know whether to take you off the treadmill, and you know, tachycardia is seen quite significantly in people with long COVID. So that was an experience. I was discharged from that. I'm not sure it did me any good, and then I was left for a couple of years just swimming in my own symptoms, you could say. And then I got another COVID infection, and everything changed for me. I started getting symptoms coming out that I'd never experienced before, and I felt quite distraught at, like, I thought I knew what my long COVID was, but now I've got a whole new vision of it. So I went back to my GP, and he said, look, there is really a proper long COVID team out there. And so I got referred to my local long COVID team, who I can tell you were superb. I had a multidisciplinary assessment, 4 people around me in a curtained off like bed space, and they did a really holistic assessment, occupational therapist, physiotherapist, psychologist, and I think there was a student there. And I number one, I've never experienced a multi-professional assessment like that before, but it was really good. And we realised very quickly that actually I needed certainly all 3 of those services, so physio, OT and psychologist, but actually they staged how I went through that service. So I saw the occupational therapist, first of all weekly, then every 2 weeks, and then monthly. And when I was coming towards the end of that, I then had about 8 months of initially weekly, but then moved on with the psychologist, and that was incredibly helpful because I'd developed cognitive dysfunction and I was a bit paralyzed by it and trying to function in my job, and trying to find workarounds and trying to accept all this and the emotions of all that. So if you can access good long COVID teams, they can be an absolute gem of a resource. They are actually highly knowledgeable because they're doing this every day of the week, and they're meeting all these diverse different patients with all their different complications. Getting your foot in the door can be difficult. Not every area has a multidisciplinary service like that, and some long COVID teams are losing their funding and closing. So you know, there are difficulties. I had a really good experience, but I actually don't know if that's still available to me now. When you come out of that service, and obviously when I was well enough to come out of that service, you want to pass it on to someone else who really needs it, but then you're back with your GP with ongoing care, and that remains difficult. GPs are doing their best, but their knowledge is limited and their knowledge varies GP to GP. I find, and I know from my discussions with Alison and other people that I know and other nurses that I know with long COVID, that every single element of this is a battle. And it's all about how well you can advocate for yourself. And I think here I am, I'm a seasoned health professional. I've had 20 years in clinical practice, nearly 15 years in academia. And I still struggle sometimes to advocate for myself in the best way in this kind of situation. So it's really quite a difficult experience, and the paper I shared before supports my own experience in a way. So I'll pass over to Alison.
So we're going to move on and look at the impact of long COVID on employment and your ability to work. But just to say, my long COVID clinic discharged me having done a few rehab courses, like I can't even remember, like how to pace and how to manage your energy. And they sent me on the English National Opera breathing course. And if anyone knows me for a long time, they might know that I'm completely tone deaf. So that made my whole family laugh. But yeah, in Buckinghamshire, it's like very rehab focused, and 3 miles down the road in Oxfordshire it's a much better service. So there is a real postcode lottery. But back to long COVID and employment. I've kind of done a summary here of what the research says. Jenny Lunt is an academic in England and has done quite a lot of work in this area. And then there's the two systematic reviews from last year. It's really hard to go back to work. Michaela's managed it. I didn't. I am better than I was cognitively, but I do have mild to moderate cognitive dysfunction. And it's the physical and cognitive limitations that make it really difficult to go back to work and sustain a return to work. Most people with long COVID either work reduced hours or lose their jobs. If you are going to succeed at work, you need to have workplace adjustments, and there needs to be a plan in place from before you go, looking at what you need, what you're going to do if there's a flare-up, because flare-ups are going to happen. And if you don't have a plan that your people you're working with and your manager haven't agreed to, you're on a high thing to high. It's not going to happen. And so a lot of people are really hard up financially. They can't go to work. They rely on disability benefits, which is fairly topical this week, and they have real financial insecurity. And also there's the emotional and psychological strain of your job being taken away, your profession being taken away. Nurses find it particularly difficult if they can't revalidate with the NMC. That's really hard for them. And given the workforce crisis we have in the NHS, it kind of breaks my heart that we don't do things a bit better. There are some best practice guidelines. The Society of Occupational Medicine published a review of the evidence about what worked in 2020. And at the back of that, there is an appendix which contains a list of all the tests you should have based on your symptoms. It's a friend of mine that led on that, and she was determined to get that information out there. The Society of Occupational Medicine updated their guide for managers. That they got one out really quickly at the beginning of COVID, and we updated it last year. And I was involved in that, and I was involved in the Royal College of Nursing's online resources. And the RCN has advice for reps, which is available to reps only, advice for members with long COVID, and then advice for managers. And so the evidence about how we should support people is out there. It just kind of doesn't often get followed. I'm going to hand back to Michaela, who's going to talk about the lack thereof.
So we don't have evidence or data about actually what is happening in terms of healthcare professionals, healthcare workers, nurses, midwives with long COVID. and what the success is of getting people back to work. But we know a lot through our work in the charity and the service users that we interact with there, and some of the stories that we hear are actually incredibly heartbreaking and very frustrating, back to the reason that Alison just said. We're struggling, for nurses out there doing their roles, and we've got healthcare professionals aligned with our, that are coming to us in our charity that have all this diverse experience, rich experience that is being lost, to patient care. What we do know is there's a lack of compassion in this whole system of return to work around long COVID. And that can obviously differ line manager to line manager. But in general, the majority of stories we hear, lack a compassionate approach. There's definitely unrealistic expectation of, return to work, when it will happen, how it will happen. Often there's a possibility to have a return to work twice, but if it fails twice, then, employers are looking to find that person the exit. Very frustratingly, redeployment is rarely considered. And then, if nurses find themselves at that point where they can't be redeployed, they can't work on reduced hours or reduced shifts, or they're not being facilitated to have adjustments, then ill health retirement can often be where they find themselves next. But that is really tricky to navigate, and it's not an easy system. And again, if you're someone with long COVID with cognitive dysfunction, this can seem absolutely insurmountable. And some of the work that we do in the charity is to support people through some of these processes and have peer support through these processes. So, what are people's lived experience of this? So an extended phase return is just not on offer to people. So a kind of whatever that the NHS considered this standard return, 4 weeks. What we've heard from service users is that they're using their annual leave to try and extend this phase return, to give them a few days each week to try and eke out that phase return. But actually, it's often not enough, because they're returning right back to the role they had before, and actually they don't have the same capabilities anymore. Often return to work is too many hours too quickly. Full-time might occur within 2 weeks. Home working isn't a possibility for lots of people. 12-hour shifts may not be possible for some people, and there's not an ability to think about that differently for people. And so, people may not be fit to work in clinical practice. And I can tell you very easily now that if I wasn't an academic, I would absolutely be in that position. I would not be fit to work. I previously worked in an ICU as a palliative care nurse in an ICU, and I worked clinically as well as palliative care, and I just would not have been able to do that job whatsoever. My return to work has been facilitated by a university that is very switched on about disability, and they don't just talk the talk, they do the deed. I've also, within that, so the infrastructure supports people with disability, but I've had a line manager that's been compassionate and really quite open-minded. I've had a good occupational health assessment, and then really my assessments from there are done. We have a dedicated disability support service and that are for students and staff, and they did a really excellent support plan for me, which my line manager took on board. And now my support plan, okay, I wouldn't choose for everybody to know, but timetabling, get hold of it. People that module leaders have to know that have this reasonable adjustment plan. So it requires me to be quite open to disclosure, but I have had a successful return to work. When I first got back to work, I had this very fast phase return that we've just talked about that was really unsuccessful. It wasn't even a proper phase return, and I was immediately struggling. I must admit, you know, my close colleagues know I've got long COVID. People see me in a mask a lot, but I wear not the actual mask, but I wear a mask. I mask my symptoms. I don't let people see how fatigued I am. I don't let people see that I'm struggling. I might be struggling cognitively. I have had to learn when I've got missing words, how to navigate around that. Stood in front of students when they're asking me something and I'm searching for words. I've had to learn techniques how to do that, and psychologist help was really good with that. What's helped me has been hybrid working has been really helpful. So when I'm not teaching and on campus, I can work at home. I've got this reasonable adjustment plan for when I'm on campus. All my classrooms are very near to my office, and you know, I have other adjustments. However, couldn't stay full time. I have had to reduce my hours, and who knows, I might have to reduce my hours again. But I still feel I've got such a lot to offer to children's nursing, and a lot of passion for my subject area, and you know, teaching future nurses. So I still want to be here. So, you know, it can work, but NHS aren't doing what something like a HEI might be doing. Pass over to Alison.
Okay, so I guess what we're saying is, if you have colleagues or managing people with long COVID, you really need to think outside the box. The NHS needs to think outside the box in relation to getting people back to work. Now, looking at the people here, a lot of you are as old or slightly older than me. You will remember when Frank Dobson brought in NHS Direct. Now, I was told a month or two ago that he did that to ensure that nurses with back injuries could stay in the workforce. So we kind of need another revolution like that, or evolution like that. But it won't just be one thing that will work. It will be many things because everybody's symptoms are different. Okay, I'm now going to just touch on the fact one of the problems we have is non-evidence-based infection prevention and control guidelines, which makes it much harder for people like Michaela and I in the clinically extremely vulnerable group to go into hospital settings, to go to GPs. I haven't been to my dentist unless I really needed to since I got long COVID. So we're just going to run you through some of the evidence. So there is compelling evidence that COVID-19 is airborne, as are most other respiratory pathogens. However, UK National Infection Prevention and Control manuals, so across the UK, haven't been updated to reflect this. And this has resulted in inappropriate protective measures being in place for both patients, staff and visitors who are all at risk. This is a slide, and we're running out of time, but this is something that Trish Greenhalgh and her colleagues pulled together that shows all the reasons why it makes sense that COVID is airborne. I'll leave you to look at it afterwards. There's another slide here, diagram here, that is all the lessons that should be learnt from the fact that COVID is airborne and the need for ventilation. Again, we're running out of time, so I won't go through it in detail. And one of the issues with our UK infection prevention and control manuals is they rely on an outdated droplet aerosol dichotomy, which defies physics. And because of this, incorrect assumptions have been made about the risk of transmission for COVID-19, and the manuals still say that it's transmitted via droplets, but no one has managed to produce any evidence to support the droplet. And there, as I said before, there's lots and lots of evidence that it is actually airborne. So this paper that I only read properly in the last 6 months because my brain was beginning to work better. I do that thing I always told my students not to, and often just read the abstract of papers. But this paper that I read properly 6 months ago or so talks about physics-based modes of transmission, and they talk about inhalation, spray, and touch. Kind of makes sense. And what they're saying is that if you use these modes of transmission, you can then identify appropriate protective measures. And if you look at this table, it really illustrates to me what a mess was made of the precautions that were used for COVID. There was an over-reliance on hand hygiene and surface cleaning. People were only expected to wear proper respiratory protective equipment if they were doing aerosol generating procedures, when actually breathing is an aerosol generating procedure. I could go on. I could get on my hobby horse, but I won't. So Supporting Healthcare Heroes, the charity that Michaela and I are both involved in, have kind of looked at this evidence and have launched a Safe Air for All campaign. Because of our charitable objectives, we're looking at safe air in healthcare settings, but we are working with colleagues who are looking at it in other settings. It should be in school as well, which is, as children's nurses, you're probably aware of. And a lot of COVID transmission happens because kids pick it up at school. Michaela, do you want to talk to this quickly?
Yep. So Alison and I, we've got all sorts of experience of being in healthcare settings, even more since we've had long COVID, because you end up this person with all these complexities. But what's it like? They're really crowded departments. What I found, my first appointment after being discharged, and I had really terrible fatigue, and I got in there and there wasn't a seat to sit, and it was really crowded, and I was just really frightened of being there. You're very close to the next person. So I was recently at a fracture clinic, don't ask, and like we were in like sardines. You're often the only person wearing a mask, and actually people think, oh, that person's, what's wrong with them? Why are they wearing a mask? Aren't they anxious? And actually, we're taking the most sensible precautions that we can in this situation. Windows aren't open or can't be open. There's a lack of ventilation in these areas. And what's really interesting is thinking about using carbon dioxide to assess the quality of ventilation in these healthcare settings. And Alison's going to talk more about that now.
Okay, so why can we use CO2 as a proxy for indoor air quality? Well, we breathe out CO2 and we breathe out respiratory pathogens. And so if you measure the CO2 in a room, it gives you an indication of how good the ventilation is. And if the CO2 is not disappearing anywhere, neither are those respiratory pathogens. So part of our Safe Air for All campaign is to make the invisible risk of poor indoor quality visible. And we're asking people to do 4 things, and I'll go through them quickly. And there's more information on our website. If you have a portable CO2 monitor, we ask that you take it with you to a healthcare setting, follow some rules we set to make sure it's as accurate as possible, take a photo of the meter reading, and post the photo on social media with the hashtag #SafeAirForAll, or upload it to a Padlet board that we've got. We have set up a loan scheme for CO2 monitors, and we also have negotiated discount codes with two of the people who provide the more expensive but good quality monitors. I have to admit, I can't always get David to take a monitor with him, but I do. We want people to tell us their stories about infection prevention and control measures that they've experienced in healthcare settings. So I have a friend who lives in the Manchester area whose husband has cancer. She has long COVID, and she has had an ongoing battle with her local hospital and the bigger tertiary centre about staff wearing masks because her husband is vulnerable and so is she. Using a HEPA filter can help bring this help with purifying the air a little bit. She gets told off for taking those in as well. So we want good experiences, but we're also interested in the poorer experiences. So we're kind of trying to gather data albeit not necessarily scientifically rigorous about what it's really like in healthcare settings. But we also would like you to contact your MP. We've prepared a briefing sheet, a fact sheet, with the Manchester Greater Hazard Centre, which can be downloaded from there, and it's on our website. And all the MPs have had a copy. The Greater Manchester Hazard Centre sent it to them, but we'd really like you to contact your MP and encourage them to do something about safe air in healthcare settings and in schools. And the last thing we'd like people to do is we produced a poster about the need to manage indoor air quality, and it's downloadable from our website. And what we'd like people to do is print off a copy of the poster, and when you go to a healthcare setting, to put it up, even if it's on the back of the loo door. And this is something that people ask for, and so we've done it. And I think it's about trying to get the word out there, and the public health messaging has been so absolutely appalling that people don't understand that COVID is airborne and that you still need to take all these precautions. The other thing we did as part of the campaign was the Greater Manchester Hazard Centre had a petition that they started last year, and then Rishi Sunak called a general election, and it got paused, and they restarted it, calling for new indoor air quality and PPE standards in healthcare settings. We didn't make the 10,000 signatures, despite a lot of work by a lot of us, for government to make a statement on it, but we decided to deliver it to Downing Street. And so this is my trip to London last week to deliver this petition. And we're told that it does get taken away and looked at, and they will respond. So that's just a bit of excitement. As I say, I'd met a couple of friends at Marylebone twice, but I've never been into central London. It was 5.5 years. It was quite interesting. So what could you do to help supporting healthcare heroes? Well, we're looking for trustees, and we're always looking for volunteers. We'd love you to participate in our Safe Air for All campaign, to fundraise for us. We're looking for people to do sponsored walks, sponsored cycle rides, sponsored whatever. You could make a donation, and you could follow us on social media and like and share or whatever our posts to get the word out there. These are the social media channels that we have. And this is how you contact us and the website. And if you go to the homepage and scroll down just a little bit, there's a section on making the invisible risk visible, and all the information I've mentioned in this presentation is available via that. And if you can't find it, just ping myself or Michaela an email. And that's it. And we have managed to allow 10 minutes for questions. I'm sorry it's that short.
Thank you, Alison.
Can you unshare, Alison?
Oh yeah, thank you. Sorry,
Yeah.
I always forget. I'm not very good at sharing screens.
Thank you. Thank you. It's Bernie Curtis, President of the ABPN, and thanking you both very much for a really, really interesting presentation. I think probably all of us that have been listening, unless we're people who've got experience, direct or indirect, of long COVID, will have learned an awful lot. So I'm very grateful that you've increased my knowledge of something I thought I knew something about, but clearly knew very, very little about. Fiona Smith can't use the microphone at the moment, so I'm being her voice. So
I saw she was putting questions in the
asked
chat.
a question which you've partly asked, which is, she says, can I ask if you feel occupational health nurses and departments are fully cognizant of the evidence and have insight into long COVID? And also, maybe the last slide answered some of that. How can the ABPN increase awareness?
Yeah, it'd be
There's
great
sort of
if
two
everyone
parts to a question.
Yeah, so occupational health. Some people are very good. Some people are very bad. I'm working with some people in Northern Ireland who have been refused ill health retirement because you get better from long COVID and this is someone who she went to a vocational rehab person, got told there was no point paying the money for it, and that was because there are occupational health professionals who think you're going to get better from long COVID. I'm now a member of the Society of Occupational Medicine and work on their long COVID group, and some of the things that people say there are quite interesting. But we're trying to change attitudes. And interestingly, I think less than half of workers across the UK have access to an occupational health department. And I know my experience when I was at London South Bank University and was off sick for a prolonged length of time was that I saw the same occupational health professional. It was a nurse, and we were able to follow through. Whereas I'd worked at the Open University for 7 weeks before I had to go off sick, and I got referred once, and actually we ran out of time for me to tell them all my symptoms. Yeah, Michaela, do you want to add anything?
Just to say that kind of the stories we hear from our service users and are very much that it isn't the occupational kind of health system, number one, hasn't got the time, so time allocated for an appointment is a fixed period, and you know, as Alison just said there, you know, I could, if someone did an assessment on me, it would take ages. And you know, once you think about one thing, you realise that your symptoms are related to this and that. It's not an easy story to tell. And actually, occupational health departments are not really interested in that. They see that as a GP's issue and like how we're going to get you back to work. And it isn't a realistic or well understood issue in the workplace, certainly in the NHS. That's what our service users tell us. Yeah.
I'm going to make one short comment. I'm so impressed by the work that you're doing. We desperately need people like you who've got long COVID to be part of our workforce for whatever fraction of time you can do without doing damage or more damage to yourself. And I think that'll be something a lot of people will feel. Mark, you had a question. If anybody else has got a question, we might have time to answer it, but if you can put it into the chat, that would be helpful as well. So over to Mark. Who's on mute?
Get myself off mute. Thanks, Bernie. Well, the question was, we've had this long debate over the last couple of weeks about the escalating welfare bill and about the growing numbers of people who are being paid PIP. But I've not heard anybody in any of that debate say actually a significant proportion of the reason we've had this massive growth is because of the proportion of this 2 million that Trish Greenhalgh's review identified actually have long COVID, and as a result of that are needing PIP to either support them into getting back to work or to support them more generally. I mean, yeah, is this not now a forgotten disease, Alison, Michaela?
It is, and people switch off when you say long COVID, and COVID's gone, and like you get weird looks when you've got a mask on. I mean, I don't go out very much, but when I do, I've got a mask on and a HEPA filter. Yeah, and yeah, I think that's another thing people need to write to their MPs about, actually, and because I voted Labour last year and really hoped, maybe I was a bit silly, that they would start looking at the evidence. I have a sister who is a Labour peer and one of the whips. And interestingly, when Anne-Marie Rafferty, a nursing prof, got made a Labour peer at Christmas, I said to Fiona, oh, I know one of the new peers. And she said, what's she like? And I said, well, she'll want the evidence. And Fiona's response was, well, she'll have to toe the party line. So I think there is this, and thankfully, some of the MPs, I don't often talk to her about politics, but some of the MPs, including my sister's flatmate in London, did get concessions this week. I don't know why, particularly given I haven't had time to read the blurb about the new NHS plan today, but they want to do preventative stuff. So why aren't they preventing long COVID? Because nobody wants to hear about it. Yeah. I better shut up and let Michaela come in because I'll just go on forever.
I think it's really interesting what you say. So a couple of things. First, when you say COVID or long COVID, you know, people around you, like, how dare you bring that up? We know we don't. We're still traumatized, and we don't want to talk about it. And the trouble is, we're still living it day in, day out. It's such a contemporary problem for us. And actually, the big thing for us is that we don't want anybody else to get it. And of course, that's not realistic. But we want to reduce that prevalence of it happening. But interestingly, the other, coming back to your question, Mark, is that clearly my social media feed is probably a bit different. It's full of long COVID stuff. And I see people in the UK who, around this PIP issue, are absolutely in crisis. Yep. Because there are masses of people being affected by these changes and they don't know how they're going to function. Their life has changed so significantly already, and they've had a successful PIP assessment, and now that's going potentially for them, so I am seeing in my social media feed, obviously that's curated to me, the impact of those changes.
Yeah, I think a lot of healthcare professionals with long COVID are living on these benefits.
Yeah,
because there is no financial support for them. The UK is one of only a very few countries that don't recognise long COVID as an occupational disease. And so, I mean, I was very careful about how I argued, because I know I have a decent pension, albeit with a 20-25% reduction because I took it so early. I will survive without my PIP, but I will have to be really, really careful. Other people are living on it. It's all they've got to live. And I know someone said to me the other day, but I know some people who are on PIP and shouldn't be. And I'm thinking, just because a titchy proportion of people have got it fraudulently doesn't mean the rest of us don't need it. And it's a really gruesome assessment that you have to go through. And they're way behind. I sent in my my renewal papers a year ago, and they've only just started looking at them. So it was extended, and I'm expecting my mobility to go up because of now I use a scooter. But yeah, I mean, it's immoral. And the fact that some of those Labour MPs stood up and some of them voted against it have maybe restored my faith in the Labour Party. But yeah, I don't know. I better not get too political.
No. So I guess apart from contacting MPs, apart from supporting the campaign, apart from I like the idea of infiltrating toilets with kind of posters and things like that we can do. That sort of thing. One of the things that we can actually do is be kind to each other and reach out to try and understand people, because I think the thing with COVID for all of us, even those who's not been directly contacted, it is such an uncomfortable diagnosis to be talking about, that people just want to go, please make it go away. So somebody a bit like you that's suffering from something is really tricky. So I think your session has really increased people's understanding and awareness. We've had, I'm sure the people here have really enjoyed it. It will be going out and be accessible to people via our link, so it will go to